Hello everyone, I am myself Dr. Rajesh Gubba. I am the general medicine educator. So in this particular section, I'll be discussing some of the very important clinical based questions in the neurology. So the first question is, we have a 75-year-old man devoid of comorbidities. He presents to the outpatient department with recurring instances of forgetting the route to his home from the nearby grocery store and a place he frequently and struggles to recall the names of the common items he interacts with daily. Upon examination, his MMSE is around 22. The neurologist proceeds to request an MRI scan of the brain, the results of which is provided below. Now, what probable diagnosis does this scenario suggest? Alzheimer's, Pick's disease, then Parkinson's disease, then pseudo dementia. So, with the age and the clinical picture given, it is suggestive of the Alzheimer's disease. Now, in case of Alzheimer's, what type of dementia is what you will have in case of the Alzheimer's? So, the type of dementia that you will have in case of the Alzheimer's, it will be cortical dementia. Now, which part of the brain gets affected first? Earliest and most serious damage is seen in the medial temporal lobe or the entorhinal cortex. Okay, so the earliest abnormality is over the medial temporal lobe, right? It is over the medial temporal lobe or the entorhinal cortex. Now, so this medial temporal lobe or entorhinal cortex is the place where you have the damage early in case of the Alzheimer's disease, right? Now, in the temporal lobe, the structure which gets affected is the hippocampus, right? The structure which gets affected is the hippocampus, and within the hippocampus, you have an important nucleus, that is nucleus of Maynard basalis, right? It is the nucleus of Maynard basalis that is being affected first. Okay. Now, because of the damage to this particular nucleus of Maynard basalis, what happens in patients with the Alzheimer's is there will be decrease in the acetylcholine levels, and not only decrease in acetylcholine levels, there will also be decrease in the norepinephrine and as well as decrease in the serotonin levels as well. Okay. So these are the neurotransmitters which are reduced in patients with the Alzheimer's disease. Now, this Alzheimer's, it is mainly because of the gene mutation, right? And the abnormality or the genetic predispositions which predispose the individual to develop the Alzheimer's is, you take on chromosome number 1, the gene that is being defective is, the defective gene is presenilin 2. Right, the defective gene is the presenilin 2, and whereas on chromosome 14 the defective gene is presenilin 1. Right, the defective gene is presenilin 1, and you take chromosome 19, the defective gene is apolipoprotein E4 allele, right? That is apolipoprotein E4 allele. That is what is being defective on the chromosome 19. Whereas chromosome 2, like you have the abnormality corresponding to the Down syndrome, right? Chromosome 2, right? You have the abnormality corresponding to Down syndrome. So these genetic predispositions, that is presenilin 2, presenilin 1, defective gene in apolipoprotein E4 allele, and as well as the Down syndrome. So these genetic predispositions are the one which will make the individual to go into a state of the Alzheimer's disease. Now, if you take the histopathology in case of the Alzheimer's, you have the amyloid protein, right? So you have the amyloid protein which is being accumulated between the neurons. Right, you have the amyloid protein which is accumulated between the neurons, and apart from this amyloid proteins, you also have neurofibrillary tangles, and these neurofibrillary tangles, they are composed of tau protein. Right, neurofibrillary tangles, they're composed of tau protein. And what will be the clinical features that you will have in case of the Alzheimer's? First and foremost, very important is amnesia, followed by that aphasia, followed by that apraxia. Okay, so amnesia, aphasia, apraxia, and then anosognosia. Right, then anosognosia. So these four are the important features, right? And these four, they progress to the development of mutism and as well as the incontinence. Right, mutism and as well as development of the incontinence. Okay, so in early stages, initially, what is being lost is the short-term memory is lost. Right, in early stages, the short-term memory is lost, and later this will progress to the loss of the long-term memory. Right, so this will later progress to the loss of long-term memory. So that is what the clinical features that you have in patients with the Alzheimer's. And what does the MRI of the brain show? So if you take the MRI of the brain in patients with the Alzheimer's, you will notice that there is blunting of gyri and as well as sulci. Right, blunting of gyri and as well as the sulci. That is what you will notice in case of the Alzheimer's disease. So this blunting of gyri and sulci, that will lead to pseudo enlargement of the ventricles. Right, there will be pseudo enlargement of the ventricles of the brain, and this will be misinterpreted as the hydrocephalus when a plain MRI is being performed. And then what is the investigation of choice in patients with the Alzheimer's? The investigation of choice is you need to do what is called the amyloid PET. Okay, so amyloid PET scan, that is the investigation of choice. And what is the treatment that you need to give is, you need to give, the drugs that we give in the treatment is donepezil. Right, the treatment that you need to give is donepezil, right? And we also have new molecule which is prescribed in the initial stages, and that particular molecule is memantine. Okay, so memantine, it's a new drug which is mostly prescribed in the initial stages, and the other molecule is rivastigmine. Right, rivastigmine, and next is galantamine. Okay, so these are the molecules which are given in the treatment of the Alzheimer's disease. Whereas you take about the other options. Why not Pick's disease? See, Pick's disease, you have damage to the frontal lobes and makes the patient aggressive or socially inappropriate. Okay, so in patients with Pick's, okay, so the patient will be aggressive or socially inappropriate. That is what you will observe in case of the Pick's disease, right? And in patients with the Pick's, it is not usually observed in elderly individual, like where you have our patient around 75 years. It is the one which is present in age less than 50 years. Then you take Parkinson's dementia. See, Parkinson's disease characteristically presents with the symptoms of bradykinesia, rigidity, and as well as resting tremors. Okay, so there will be slowness of movement, there will be rigidity, and as well as the resting tremors. So these will be the features of the Parkinson's disease, right? Whereas you take pseudo dementia. Patients with pseudo dementia, they display cognitive deficits. Right, they display cognitive deficits or the memory issues. So that is what you will observe in case of the pseudo dementia, right? So the answer to this particular question is Alzheimer's, where it is a cortical dementia, right? moving on to the next question. See, at the same time, at the same question, let me try to discuss the cortical dementia, presenile dementia, subcortical dementia, where all you will have all these. Right. So the first one is the cortical dementia. So cortical dementia, where all you will have, one is Alzheimer's disease and even Pick's disease. So both of them, it is cortical dementia. Then you take presenile dementia. Presenile dementia, it is observed in patients with the Down syndrome, right? And what is that clinical condition where you have subcortical atrophy causing dementia is, that is, it is observed in Parkinson's disease, it is observed in Huntington's disease, and it is observed in AIDS related dementia. Okay, so that is subcortical atrophy. Then pseudodementia. Pseudodementia is a presentation of the depression. Right, pseudodementia, it is a presentation of depression. Then what is the clinical condition where you have Lewy body dementia? Lewy bodies are present in Parkinson's disease, right, and Lewy bodies are also present in the Lewy body dementia. Next is the presence of Hirona bodies. So the inclusion bodies, that is the Hirona bodies, they are present in case of the Alzheimer's disease, right, present in case of the Alzheimer's disease. Okay, and the another scenario is a young patient who is presenting with dementia and as well as the myoclonus. What could be the differential diagnosis? That is Creutzfeldt-Jakob disease, and that too what type of Creutzfeldt-Jakob disease? That is variant Creutzfeldt-Jakob disease. Okay, so that is a young patient has dementia and myoclonus. What would be the cause? And a patient around 50 years, along with dementia, the individual is also having chorea. Then what is this suggestive of? This is suggestive of Huntington's disease, right? This is suggestive of the Huntington's disease. Okay, so this is about a question related to dementia, that is Alzheimer's. Now you take the second important clinical based question. We have a 80-year-old female presents to the outpatient clinic with complaints of forgetfulness over the past 6 months. A MMSE score is being done where the score is around 90 out of 30. Given the clinical suspicion of Alzheimer's disease, which of the following can be done for further diagnostic evaluation to confirm the diagnosis? Plain MRI, functional MRI, head CT, then MMSE. So here the diagnosis which has to be done, or the workup that has to be done to confirm the diagnosis, is the functional MRI. So what is this functional MRI? See, functional MRI, it is a neuroimaging technique that measures the brain activity. Right, that measures the brain activity by detecting the changes in the blood flow. Right, by detecting the changes in blood flow, right? And in patients suspected of having the Alzheimer's disease, it is the functional MRI that will assess the metabolic activity in specific brain regions. Right, so that will assess the metabolic activity in specific brain regions. Okay, now, so where is this metabolic activity assessed? That is in the parietal and the temporal lobes. Right, that is in parietal and as well as temporal lobes. So these are the two lobes which are commonly affected by the disease, that is the Alzheimer's, right? And in case of Alzheimer's, if you take this MMSE, that is mini mental state examination, it is a screening test. Okay, so this is a screening test where false positives may occur, right? So where is that false positive may be observed is, you may observe false positives in the state of depression. Right, in the state of depression there can be false positives. Then you take this functional MRI. Functional MRI is the one which will identify the metabolism, right, which will identify the metabolism in the parietal lobe and as well as the temporal lobe, right? And this functional MRI is the one which is preferred over the plain MRI. Right, functional MRI is the one which is preferred over the plain MRI. Then what are the other imaging modalities? The other imaging modalities that can be done in case of the Alzheimer's will be CT scan, then volumetric MRI, then FDG glucose PET scan, right, FDG glucose PET scan. But what is being preferred? It is amyloid PET scan, right? So it is amyloid PET scan which is a preferred investigation for the dementia, right? So the answer to this question is what? That is the functional MRI. That is a preferred investigation. Moving on to the next question. We have a 32-year-old female presents to the neurology clinic with progressive memory loss and difficulty in the daily functioning. Her family reports that she frequently forgets recent events, repeats questions, and struggles with tasks that were once routine for her. Which of the following drugs are not used in the condition of this patient, and what is this patient suffering from? Donepezil, memantine, rivastigmine, and then tacrine. So the question is, which of the following are not used in the condition of this patient who is suffering from? So we use donepezil, memantine, and as well as rivastigmine, but tacrine is not used. And what exactly is this particular tacrine? So tacrine is known as tetrahydroaminoacridine, right? So this was actually one of the first drug used in the treatment of the Alzheimer's disease, right? But this particular tacrine, it is now discontinued. Right, this tacrine, it is discontinued. Why it is discontinued? That is due to significant hepatotoxicity. Right, that is due to significant hepatotoxicity. That is the reason why this tacrine is being stopped. And now, what are the safer alternatives? So safer alternatives are donepezil, memantine, then rivastigmine. So these are the safer alternatives: donepezil, memantine, and as well as the rivastigmine. Now you take this description of these molecules, that is donepezil. See, donepezil is an acetylcholinesterase inhibitor. Right, it is an acetylcholinesterase inhibitor. And this acetylcholinesterase inhibitor, it is given in the initial stages. Right, it is given in the initial stages to treat the Alzheimer's. Whereas you take this memantine. Memantine, it is an NMDA receptor antagonist. Right, it is an NMDA receptor antagonist, and this is also given in the treatment of the Alzheimer's. Then followed by that, rivastigmine. Rivastigmine, it is also an acetylcholinesterase enzyme inhibitor. Okay, so your rivastigmine and as well as the donepezil, by inhibiting this acetylcholinesterase enzyme, what they will do to the acetylcholine levels? They increase the acetylcholine levels. Right, in patients with Alzheimer's, what is happening? The acetylcholine levels are reduced. So this donepezil and as well as rivastigmine, they will increase the acetylcholine levels. Whereas memantine is what? Memantine is a NMDA receptor antagonist. So that will help to regulate the glutamate activity. Okay, so this will help to regulate the glutamate activity within the brain. Okay, and thereby this memantine will improve the cognitive function. Right, memantine will improve the cognitive function. So that is about the treatment of the Alzheimer's. And next question. So we have a 55-year-old male presenting to the neurology clinic with progressive weakness and muscle atrophy in his limbs. He reports difficulty in performing the daily activities such as walking and lifting the objects. Upon examination, the patient exhibits muscle fasciculation and hyperreflexia. All of the factors contributing to the pathology of the condition except the options are defective protein degradation in the neuron, defective RNA processing, increased glutamate levels, increased methionine levels. Okay, so now what is the answer in this question? First of all, what is the diagnosis? See, this particular question, the diagnosis, it is suggestive of motor neuron disease, and that too, which type of motor neuron disease? That is amyotrophic lateral sclerosis. Why is it amyotrophic lateral sclerosis? Because in amyotrophic lateral sclerosis, you have the features of the upper motor neuron lesion and you have the features of the lower motor neuron lesion as well. Okay, so it exhibits muscle fasciculation. So this will be lower motor neuron lesion problem, and it exhibits hyperreflexia. So this is suggestive of the upper motor neuron lesion. So you have a combination of both upper motor neuron and as well as lower motor neuron problem, right? So that is the reason why it is suggestive of amyotrophic lateral sclerosis. And in amyotrophic lateral sclerosis, there is defective protein degradation in the neuron, and there is also defective RNA processing. There is also increased glutamate levels. But what will happen to methionine levels? Increased methionine levels, that is not the feature of the amyotrophic lateral sclerosis, right? So amyotrophic lateral sclerosis, as such, what exactly it is? It is a neurodegenerative disorder which is characterized by degeneration of the upper motor neurons and as well as the degeneration of the lower motor neurons as well. And due to degeneration of upper and as well as lower motor neurons, this will lead to the development of the muscle weakness. Right? So this will lead to the development of muscle weakness, atrophy, and eventually paralysis, right? And there are several factors that will contribute to the pathology of amyotrophic lateral sclerosis. One of the very important factor is defective protein degradation in the neurons, okay? And second is defective RNA processing, right? Defective RNA processing. And next, in amyotrophic lateral sclerosis, dysfunctional glutamate handling mechanisms such as impaired glutamate uptake. Okay, so there is impaired glutamate uptake. So impaired glutamate uptake by the astrocytes, and there is downregulation of the glutamate transporters, right? There is downregulation of the glutamate transporters, okay? And in case of the amyotrophic lateral sclerosis, what are the neurotransmitters which are elevated? So there is increase in the excitatory neurotransmitters, okay? So what is that excitatory neurotransmitters which are elevated is there will be increase in the glutamate levels, and there will also be increase in the aspartate levels. So excitatory damage due to amino acids excitotoxicity. Glutamate and aspartate levels are elevated, and that will be causing the excitotoxicity. Now, this excessive glutamate accumulation overactivates the glutamate receptors, right? This excessive glutamate accumulation overactivates the glutamate receptors, and once the glutamate receptors are overactivated, this will trigger the calcium influx, right? This will trigger the calcium influx, and subsequently it will cause the neuronal injury, right? And this excitotoxicity contributes to motor neuron degeneration in amyotrophic lateral sclerosis, and it is implicated in the pathogenesis of disease, right? And very important is in patients with amyotrophic lateral sclerosis, the increase in methionine levels will not be there, right? Increase in methionine levels will not be there, okay? So the answer here is D, because the question asked is except, right? Moving on to the next question, right? So we have a 20-year-old male was brought to the clinic by his parents, and with complaints of weakness in his legs for one day. On examination by the physician, he had fasciculations and a slapping gait, absent knee jerk in one leg, and brisk biceps jerk. Doctor advised electromyography, which showed a denervation pattern in lower motor neurons involved. Which of the following is not a treatment used to manage this patient? Physiotherapy, finger extension splint, tracheostomy, steroids. Now, what is this clinical picture suggestive of? See, the individual is having fasciculations, which is a lower motor neuron problem. The individual is having brisk bicep jerk, which is an upper motor neuron problem. And electromyography reveals the denervation pattern in the element involved. So, which of the following is not a treatment used? So, what is this suggestive of? First again, this is also the clinical picture suggestive of the amyotrophic lateral sclerosis. So, here you have weakness of legs, fasciculations, then slapping gait, brisk knee reflexes, and as well as the absent knee jerk, right? And absent knee jerk. Now, what is the treatment in case of amyotrophic lateral sclerosis? Physiotherapy is very much required, finger extension splint, and tracheostomy is required if the individual goes into a state of respiratory failure due to muscle paralysis, right? If the individual goes into a state of respiratory failure due to respiratory muscle paralysis, there the patient initially will be requiring endotracheal intubation. Later he has to get switched on to the tracheostomy. But steroids, they have no much role in the treatment of amyotrophic lateral sclerosis. And apart from that, the drugs which are very important is riluzole. So if you take this riluzole is known to decrease the glutamate, and riluzole is known to decrease the aspartate levels as well. Okay, so riluzole, it will decrease both. It will decrease the glutamate and it will decrease the aspartate as well. And it is one of the few drugs approved for the treatment of the amyotrophic lateral sclerosis. And another important molecule is the edaverone. Right? Another important molecule is the edaverone. See, another medication which is used in the treatment of amyotrophic lateral sclerosis is that which is thought to have the antioxidant properties. Right, which is thought to have the antioxidant properties. Okay, whereas you take this steroids, they are not used for the management of the amyotrophic lateral sclerosis. Whereas you take this physiotherapy. So this physiotherapy, it is very much crucial part of the management of the amyotrophic lateral sclerosis. So this physiotherapy, it helps in maintaining the muscle strength. It helps in maintaining the flexibility. It helps in the mobility of the muscle as long as possible. Next is the finger extension splint. That is used to prevent or manage the contractures. That is used to prevent or manage the contractions. That is what is the finger extension splint. Next is the tracheostomy. See, this procedure may be necessary to support the respiratory function as the amyotrophic lateral sclerosis progresses and the individual will develop respiratory failure. So that is the reason why tracheostomy is required. Okay. So steroids have no role in the treatment of the amyotrophic lateral sclerosis. So next question. We have a 65-year-old male presenting with progressive dysphagia, dysarthria, and difficulty in chewing for the past few months. He also reports frequent choking episodes while eating and speech changes characterized by slurred speech and nasal quality. On examination, the patient demonstrates the weakness and atrophy of the tongue, palate, and pharyngeal muscles, along with the absent gag reflex and weakness of the shoulders. Which of the following nerves are affected in this condition? There is damage to 9, 10, 11, 12 cranial nerves. There is damage to 9, 10, 11 cranial nerves, and damage to 7, 9, 11. Fourth option, damage to 9, 10, 12 cranial nerves. So, based on the clinical scenario which has been given, the patient is said to be having what is called as bulbar palsy. Now, what are the points suggestive of right? What are the points suggestive of the bulbar palsy? So there is weakness or paralysis of the muscles innervated by the motor nuclei of several cranial nerves which are located in the bulbar region of the brainstem. So first and foremost, what is the answer? It is damage to 9, 10, 11 and 12 cranial nerves. So the patient is having dysphagia, right? So the patient is having dysphagia. What is the cranial nerve which is being affected? That is the ninth cranial nerve, that is glossopharyngeal, because this glossopharyngeal is the one which is responsible for innervating to the pharyngeal muscles which is required for swallowing, right? And the next important is the individual is also having dysarthria and as well as difficulty in chewing. So that means the individual has the paralysis of the tongue, which corresponds to the cranial nerve 12, right? Which corresponds to cranial nerve 12. Whereas, what is that points suggestive of involvement of the cranial nerve 10? So there is like choking episodes while eating, and speech changes are there, and there is also slurred speech and nasal quality, and there is also dysphagia. So presence of dysphagia, slurred speech, choking quality, right? This is suggestive of the involvement of the 10th cranial nerve, right? This is suggestive of involvement of the 10th cranial nerve. And the patient is having, so 9, 10 and as well as the 12 is affected as of now in the clinical picture which is being given. But in that bulbar region of the medulla oblongata, there is also 11th cranial nerve which is present. Usually 11th cranial nerve is the one which will supply sternocleidomastoid and as well as trapezius muscle. And once there is damage to the 11th cranial nerve, this will contribute to abnormality in the head movement. This will contribute to abnormality in the shoulder elevation. So that is about the 11th cranial nerve involvement. Okay. So the answer to this particular question is damage to 9, 10, 11, 12 cranial nerves where the patient is having what is called as the bulbar palsy. Okay. So the answer is A, first option. Now, so moving to the next question, we have a 30-year-old man presents to the emergency department complaining of recurrent episodes of weakness and paralysis, particularly after meals. Initially, the healthcare provider suspects malingering due to the episodic nature of the symptoms. So there is recurrent episodes of weakness and as well as paralysis, particularly after meals. So initially the healthcare provider thought it would be some malingering. However, further evaluation revealed these episodes consistently occur after consuming carbohydrate-rich diet. These symptoms are consistently present after consuming carbohydrate-rich diet. So all are correct about the workup of this patient except serum potassium is either normal or less, CPK-MM level is normal, nerve conduction velocity is normal, then genetic studies showed the autosomal recessive inheritance. So first of all, what is this clinical picture suggestive of? Okay, so this clinical picture, it is suggestive of, so there is complaining of recurrent episodes of weakness and paralysis, particularly after the meals. And after consuming the carbohydrate rich meal, the patient is having this following clinical scenario. So this is suggestive of hypokalemic periodic paralysis. Right, hypokalemic periodic paralysis. Okay, and this hypokalemic periodic paralysis will not have autosomal recessive type of inheritance. The type of inheritance that you will have is autosomal dominant type of inheritance. And this hypokalemic periodic paralysis, it is one of the rare neuromuscular disorder which is characterized by recurrent episodes of the muscle weakness. Okay, there is recurrent episodes of muscle weakness and as well as the paralysis. So paralysis and recurrent episodes of weakness, that is suggestive of the hypokalemia, right? Whereas serum potassium levels is either normal or less. Yes, that can happen in patients with hypokalemic periodic paralysis. Whereas you take the CPK-MM levels. The CPK-MM levels are normal and nerve conduction velocities are also normal. And genetic studies shows autosomal dominant type of inheritance but not autosomal recessive type of inheritance in case of the hypokalemic periodic paralysis. Alright. So this is about a question on the hypochannelopathy. Next is, we have a 25-year-old female presents to the neurology clinic with complaints of the progressive weakness and muscle wasting in her lower extremities. Upon examination, her legs exhibit a characteristic stock leg appearance with muscle atrophy, particularly affecting the peroneal muscles. Right, particularly affecting the peroneal muscles. Which of the following is not a feature of the disease that the patient is suffering from? Champagne bottle appearance, foot contractures, onion bulb appearance on the biopsy. Next is the waddling gait. See, so patient is having progressive weakness and as well as muscle wasting in her lower extremities. Upon examination, her legs exhibit a characteristic stork leg appearance with muscle atrophy, right, with muscle atrophy, particularly affecting the peroneal muscles. Particularly affecting the peroneal muscles. Okay, so what is this clinical diagnosis suggestive of? So the clinical diagnosis is suggestive of Charcot-Marie tooth disease. So Charcot-Marie tooth disease, it is a neurological disorder, right? It is a hereditary neurological disorder which is characterized by progressive muscle weakness. Right, which is characterized by progressive muscle weakness, and there is also muscle wasting as well, right? And Charcot-Marie, it is an inherited disorder where you have abnormality or the problem in the peripheral nerves, right? Where you have abnormality or the problem in the peripheral nerves. Okay, and this waddling gait, it is not the characteristic feature of the Charcot-Marie tooth disease, right? And this waddling gait, it is observed in patients with Duchenne's muscular dystrophy. Okay, so it is commonly observed in conditions such as DMD, where progressive muscle weakness affects the pelvic girdle. Why is this waddling gait? This particular waddling gait is mainly due to weakness of the pelvic girdle muscles. And weakness of this pelvic girdle muscles will lead to the abnormal gait pattern which resembles the waddling. Now, champagne bottle appearance. So, you see the limbs of these individuals. So, if you observe the limbs, this champagne bottle appearance, or this we call it as stork leg appearance. Right, this we call it as the stork leg appearance. Okay, why is this? That is mainly because of the peroneal muscle atrophy. Right, so that is because of the peroneal muscle atrophy, right? And you take in the foot, there are also contractures. So contractures in the foot, right, contractures in the foot may also develop, and that is due to the nerve involvement. That is due to the peripheral nerve involvement. And in these individuals, you will notice that there will be thickened nerves. So these thickened nerves on biopsy, right, so these thick nerves on biopsy, you will notice the presence of the onion bulb appearance. You will notice the presence of onion bulb appearance. So champagne bottle appearance, foot contractures, onion bulb appearance, all these are the features suggestive of the Charcot-Marie tooth disease, right? Moving on to the next question. Which of the following statements about the Anderson-Tawil syndrome is not accurate? Patients with Anderson-Tawil syndrome presents in the childhood with spontaneous attacks of the paralysis, which may be associated with low, normal or elevated potassium levels. Second, Anderson-Tawil syndrome can be diagnosed based on the ECG evidence of the enlarged U waves, ventricular ectopy, and a prolonged QTC or QU interval. The characteristic facial appearance of the Anderson-Tawil syndrome include long nose, widely spaced ears, and prominent chin. Fourth option, Anderson-Tawil syndrome is a rare genetic disorder which is caused by variants in KCNJ2 gene. Okay, so These four are the options, and in case of the Anderson-Tawil syndrome, which is the inaccurate or incorrect statement, the incorrect statement will be the Anderson-Tawil syndrome can be diagnosed based on the ECG evidence of enlarged U waves, ventricular ectopy, or prolonged QTC or QU interval, right? That is not correct in case of the Anderson-Tawil syndrome. Let me discuss about the ATS, that is Anderson-Tawil syndrome. These patients with Anderson-Tawil syndrome, they have long nose, widely spaced ears, and as well as the prominent chin as well, right? And these patients, they have a characteristic facial anomalies. Okay, so they have characteristic faces, right? They have characteristic dental anomalies. There will also be presence of small hands and as well as feet, right? And along with these features, any of the two following features are present. What are the other two features that can be there is presence of low set ears, then widely spaced eyes, and there will be small mandible and fifth digit clinodactyly, or they'll have what is called syndactyly. So syndactyly, where there will be fusion of the digits of mainly the toes. That is what you will observe in case of Anderson-Tawil syndrome. So along with these features, that is abnormal faces, dental anomalies, small hands and feet, any of the two, right? Any of the two should be present, right? And this Anderson-Tawil syndrome, it is a potassium channel defect. Right, Anderson-Tawil syndrome, it is a potassium channel defect where you will have a prolonged QT interval, right, where you have a prolonged QT interval, and these patients, they will have episodic skeletal muscle weakness, right? There will be episodic skeletal muscle weakness, and these patients, they will have bidirectional ventricular tachycardia. There will be bidirectional ventricular tachycardia, and this can predispose to, or this can progress to development of tachyarrhythmias, that is in the form of the ventricular fibrillation. Okay, so in Anderson-Tawil syndrome, you will have potassium levels being either low, normal, or the elevated potassium. Okay, and the ECG, what it will show you? The ECG will show you that there is diagnosed based on the ECG with enlarged U waves that are not present. Enlarged U waves will not be there. Ventricular ectopics will not be there. Directly ventricular tachycardia will be there, right? Bidirectional VT will be there. Okay, and prolonged QT interval, yes, it can be, but these enlarged U waves and ventricular ectopics are not found in case of the Anderson-Tawil syndrome. And long nose, widely spaced ears, and prominent chin, that is a feature of Anderson-Tawil syndrome. And it's a rare genetic disorder caused by variants in the KCN-J2 gene. Okay, so that is the abnormality in case of the Anderson-Tawil syndrome, right? So moving on to the next question. So we have a 2-year-old child presents to the pediatrician's office accompanied by their mother, who reports the episodes of repeated blinking of the eyes followed by sudden unresponsiveness. The child may appear to be taking normally and then suddenly becomes unconscious, only to resume the activity as if nothing has happened. What is the drug of choice for this patient? Valproate, lamotrigine, carbamazepine, then the ethosuximide. Okay, so what is this clinical picture suggestive of? This clinical picture, it is suggestive of the absent seizures, right? The clinical picture, it is suggestive of the absent seizures. Now in case of absent seizures, how do you work up is, that is by EEG. So one is the clinical picture, whatever has been given to you, where there can be like staring look or repeated blinking of the eyes. Suddenly the individual becomes unresponsive and there is no postictal confusion. The individual will return back to normal consciousness. right? The individual will return back to the normal consciousness immediately, and he will behave as if nothing has happened. Okay, so what is this EEG suggestive of? This particular EEG shows 3 hertz spike and wave pattern. This EEG shows 3 hertz spike and wave pattern, and in case of absence seizures in age group less than 4 years, the drug of choice will be ethosuximide, and age more than 4 years, the drug that you need to give is the valproic acid has to be given. And this valproic acid, why isn't it given in children less than 4 years? Because this valproic acid is associated with the hepatotoxicity, right? And this hepatotoxicity, that cannot be tolerated by child less than 4 years. That is the reason why we avoid giving valproate less than 4 years. The preferred molecule is the ethosuximide. So the answer in this particular question is the ethosuximide, right? So this is one of the important question related to the absence seizures.